this is the time to go into high-level technology, where medical profession is being revolutionized. So I'm just going to invite, first of all, my colleagues who have come all the way from different parts of the world, and they will be joining me on the stage. This session is about how can you hospitalize a patient at home? How do you manage a chronic disease with a patient staying at home as good as they are in hospital? So just to clear any conflicts, I'm an orthopedic surgeon based at Harley Street, London, Microsoft certified specialist and fellow in clinical telemedicine. Current role is CTO of the innovation role of the Health Bank Global in UAE. I want to invite Professor Bilal Ahmed on stage to take the chair. Professor Bilal's introduction is here. The gentleman needs an applause. Let's give him a big warm round of applause as he joins the stage. He is one of our heroes who actually represented Pakistan managing COVID in New York, and he's also the regional telehealth lead. I want to invite Dr. Somia Iqtidar, Associate Professor, King Edward Medical College, and I think Somia needs no introduction. If Somia is here, she can join the session in a round of applause. So she would be joining it soon. And then we have Professor Farhan Isa, a very popular pathologist in Pakistan, has a lot of contribution to the fraternity. So I invite Professor Farhan Isa on stage. He's the patron of Pakistan Society of Microbiology, as well Director of Operations for Isa Lab. I want to invite one of my colleagues from NHS UK, Miss Kirsty Griffin. She's a registered nurse in UK, former emergency department senior nurse at NHS and American Hospital in UK, Dubai, and she also is a lead care plan nurse for the Health Bank Global. So with all being said, and once Somia comes in, she will be able to join the table. So I take opportunity to, first of all, give you a brief introduction of what we're going to talk about. What is home care, virtual home care? I think you know about nurse going to a patient's home and taking blood pressure and recording on a form. But if that is virtual, which means that the patient has a device, and that device is being the connection between the patient and the doctor who's not sitting there. So a dashboard somewhere or anywhere in the country where all the blood pressure, pulse, temperature, glucose, heart rate, and complex readings like interleukin 6 and other things can get recorded. We can make clinical decisions as good as we are with the patient. So that is remote monitoring and virtual home care. Basically, it is a connected healthcare system where a lot of doctors, nurses, healthcare planners are involved, and they are basically converting your home into a ward at home or a bed or hospital bed at home. And there are 4 components. In this care system, you can have a consultation, an outpatient consultation, whether in person or online, just like a standard practice. Then you can have a personalized care plan, like diabetic care plan, hypertension care plan, and you choose the right vital signs to manage that thing. Like you don't have to pick up blood pressure every time, but choose the right vital sign and monitor that. And then, of course, the most interesting part is automatic triggers. Now, automatic triggers mean that a person gets involved the moment blood pressure rises. We don't have to wait for someone to call the doctor. The dashboard is telling, or the message going out to a GP, the blood pressure is rising. Or if it's early rise, the nurse gets informed. If it's a very critical rise, the specialist gets informed. It's emergency, ambulance gets called right away. We don't have to wait. Ambulance gets called from that particular point. So why we need to do it? What's the rationale of doing this? Well, first of all, before we go into rationale, we see the possibility. Can we virtualize hospital level of care at home? I think if this question is answered, only then we can move forward. Can we virtualize hospital level care at home? Well, first of all, let's take a look at what we do in hospitals. We do a patient profile, hospital address, family members, etc. We do health profile of the patient. What's your history like? Any drug history? All this can be done over the phone or virtually by a nurse. Then the specialist can be assessed online. Then we have a disease-specific care plan. In wards, what we do, इसका blood pressure record कर लो, इसका ये कर लो, इसका spine pressure देख लो, इसका back पे आप massage करें ताकि pressure sore नहीं हो. So we give a care plan, and that care plan is specific to that patient's condition. So if that patient's condition can be virtually managed by distance, we can give the same care plan, and the nurse can schedule a visit, like twice a day. By the way, you must have noticed that I mentioned chronic condition. I'm not talking about life-threatening acute conditions, because there you need the nurse right away next door. But here, the nurse can schedule visits twice a day, thrice a day, once a day, or you can have a nurse at home. Then charting the signs. The nurse will chart on a digital form, and the digital form is shared on the electronic dashboard. Now, what that means is that any abnormality is picked well before it gets very critical. And that is the advantage. Now, all of us here, medical professionals, know that the earlier we pick up the abnormality, the better we are in managing the care. This whole system is designed on that philosophy, how to reduce the time to intervention. Not the intervention, the time to intervention. So that is the whole system based on that. As a fluid balance, sometimes you require a nurse for that if the patient is not literate to tell how much was the urine bag volume. Medications, we can prescribe online. We can dispense online, or a nurse visiting the patient can inject, and then taking actions. As I said before, the call to trigger action is that if the blood pressure goes very high, don't wait. The message goes on WhatsApp and on the dashboard to the relevant PE team to respond. So what can we manage? I think you're familiar with all of them. I'm sure that, let me just go back again. I just touched that button. Yeah. So you're familiar with all of these conditions. They're all safely manageable at home by virtuality. Now, it's not just my opinion. It's a research-based information. And I think we just heard from the PSIM that evidence-based medicine up now, we are following that, and we are only giving everything on the slide comes here after there's a research backup. If you look at the last part of that, you don't have to be ill to be managed virtually. You have a special condition, for example, mother and child care. You go to GP too often. What's wrong with my child? He's not crying, he's not smiling, he's not looking up, he's not moving his neck. These little nifty questions can be managed by a virtual home care system very effectively. So not only nursing care, but there is a parallel support to that, like physiotherapy. It can be online, can be in person, acupuncture, breathing exercises, mental health support, not for the patient only, but the caregiver at home as well, because they can get very stressed. Pressure sore care, anti-thrombosis care, fluid balance, stoma bag, urinary catheter, nasogastric, phlebotomy service. Dr. Farhani is sitting there, he can tell us more about that. How can we integrate online path lab, feeding assistance, and general nursing care. All of this is the support structure of virtual home care system. So what are the advantages? There are many, but let me put some of them here. It is, first of all, it's very personalized, very patient-centric. You decide a plan according to the patient's very condition. Not only the medical condition of the patient, but also see the circumstances, what is manageable. The hospitalization can be very short. I give you one example of my patients in UK. Once I do a knee replacement, they could stay 5 days. With the virtual home care system, I can send them at third day. So I save 2 hospital beds. Somebody else can take that bed and be operated. So there's a practical advantage of that. And then you can even avoid hospitalization. Unstable diabetes, slightly troublesome hypertension, they can be all managed on that kind of system. And it's a very connected care model. The nurse, the doctor, the specialist, the care coordinator, the relative of the patient as well, they're all connected on the dashboard. That is the real strength of the system. That a relative of the patient sitting in London, in America, can say, मेरी माँ को दवाई दी गई या नहीं दी गई, इसकी ग्लूकोज लेट हो रही है, इसका शुगर लेवल ऊपर जा रहा है, who is looking after that? So everybody gets involved. Basically the system empowers the patient. The eventuality of this is the patient is empowered. The doctor is available, the patient is empowered. And then again I say early intervention. I love this word, call to intervention, time to intervention. I've seen this doing miracles. And then of course the teamwork is very efficient, paperless. The impact is there's a minimal cross-infection risk. Patient at home. Have you heard of complicated hospital-acquired infections? I think in UK, 11% of workload, admission load, is hospital-acquired infections, patient getting readmitted. That is avoidable. Of course, quick call to action, reduced social burden. That is a very important aspect which gets ignored. हमारे मुल्क में जब एक पेशेंट हॉस्पिटल एडमिट होता है, मैं अपने मुल्क की बात कर रहा हूँ, साथ उसके 4 लोग एडमिट होते हैं. Now that is a social burden that the son has to say कि बाहर से जाके दवाइयाँ कौन लाएगा. In UK, America, maybe this is not the problem, but in our country, that is an issue. So there is no social burden. You can stay at home, be hospitalized. Coordination is better. Cost saving. Now, cost saving decreases for the patient, but also it benefits the hospital system because the patient never loses track of the doctor. And of course, the care envelope is wider. You can manage 2 or 3 multiple conditions in single hospitalization. So, evidence-based. I will give this presentation to PSIM. They already got it, and they're happy to distribute it. Please share the links, and you can see that. I also constantly write in the journal of PSIM. About 7 or 8 publications have already gone there along with my book. So I'm grateful to PSIM to let me express my kind of feelings and work through their journal. So the cost, the outcome, and the patient satisfaction, all of them positively affected by virtual home care system. And the evidence is plethora. I've just put 3 papers here, and you can see that this is not just my feeling or my observation, it's internationally acclaimed. So how we do it? Burning question. Let's make it simple. First of all, we create a profile of the patient. A specialist will make a care plan. A disease-specific vital sign will be picked up, and the relevant medical devices will be offered to the patient. Patient can buy, or patient can use simple devices, simple blood pressure kit, and just type the reading in. Then the vital signs, then I think it's an important point here. 120 systolic blood pressure is not normal for everyone. It can be 130 for a person of age 75. So the specialist can choose what is normal for my patient. I'm talking about very personalized care. What is the low normal for this patient? Because that is where the alarms will be set up. Anything going beyond that normal I set up will be triggered at nurse, GP, or specialist level. So it's a very personalized care level. And then of course the live readings of those vital signs will be available. You can choose you want the nurse every now and then, 6 hourly, once a day, or once a week even. And then of course the electronic medical records are created in text, graphs, images, and videos. So that's the, I'm just going to show you some screenshots how we do it. We are doing it in several countries, and that is how we start. First of all, we do a consultation with a specialist. It could be a physician, could be a surgeon. And after that, the care plan is made just like that. Just focus on the round, there's marking there, circle there. So we select the patient. After that, we select a medical condition, and then we choose the care plan type. And then we go to diagnosis. What is a working diagnosis of that care plan? CCF, chronic renal failure, COPD, and then we go into the monitoring requirement. Do we want the nurse on call, or do we want the nurse just once a week? Then we select the monitoring period. You can start from tomorrow, and you can end up for a week. And then we go to assign support healthcare professionals. It could be 1 or 2 nurses, 1 general nurse and 1 wound care nurse. Then a family physician who's going to buffer between nurse and a specialist. Anything which doesn't require a specialist, but more than the nurse caliber, GP is there. Online call center, 24/7 GP for that patient. And then comes the specialist. It could be a spinal surgeon, it could be an orthopedic surgeon, a physician, and a nephrologist together. Depends on how many people you want to involve. Then comes the most critical part, the vital signs. You pick the vital signs relevant to that patient, And then you choose the readings. You can say, well, I want my blood pressure higher level to be triggered only at this level. So that is called personalized care, that you come down to nitty-gritty, come to micro level of management. And then you go to hydration status, that how you want the nurse visiting the patient to monitor the hydration status. If you've heard of Rothman index had a hydration status calibration. That patient is being discharged from home, 9% of them sometimes go back to hospital because of dehydration. So Rothman index or early warning score system is based on hydration. And that is where that's why I included that into the software. I designed this whole interface with my patient in mind. And that is how we mostly practice medicine in general, in NHS. And I'm sure it'll echo to your side as well, in most, if not all. So then we prescribe medication, and then we go to the final point, assign instructions. I've got a care team, this guy should do this guy should do this, and then I can update instructions anytime as a care plan leader, the specialist. And that is how we start. Then you can preview the care plan as a document. This document stands between all the people involved in this patient's care. They can look at this care plan, it will keep developing now. This document will be the discharge summary, by the way, the automatic artificial intelligence-led discharge summary. It could be a 20-page document at the end. This is the pivotal document shared between the patient, not with the relatives, but with the patient's doctor, nurse, and GP. And it will keep developing a history. It's like a case note. And then, of course, we can view the dashboard. Now, that is the dashboard. Now, this is accessible to the patient and the patient assigned relative. Patient कहता है जी मेरा बेटा अमेरिका में होता है, उसको बड़ी फिक्र है मेरी, उसको भी दिखाएं. So we can give a link to that patient's son in America, and he can even check what's my mother's blood pressure like anytime. This program of ours is getting very involved in America and Britain for overseas Pakistanis, and they want to actually get involved in the care of the loved ones back in Pakistan. 8 or 9 million people live outside in Pakistan. So this is now, how does it look like? It looks like this. I've just picked one. Just pay attention to this, please, on the screen. The blood pressure rising to 3 triangles, three cones. And that's a critical warning. And then we know this is on the dashboard displayed in Dubai and Pakistan and wherever. And the nurses are constantly sitting there and making judgments. Although it's automatic, but the nurses are watching it. One of them is sitting here, Kirsty Griffin. She is on the dashboard in Dubai. She's watching it and she makes plans if something goes up and down. We did not put the sound triggers because their eyes are trained to look at for abnormality. So, and then you can go for the last 10 readings. You can pick one box, go for the last 10 readings to see the perspective. And then you can go further last 10 readings. So that way you can see the whole history before you make a clinical judgment. There's so many able doctors sitting here and they understand the value of this backtracking. That what's the pattern, not one reading. See the pattern. Is it fluctuating or stable? So, and then we go for the triggers. Simple rising of blood pressure, nurse will call, don't take too much salt, or make sure you take your next dose in time. That's the nurse calling the patient. Slightly high, the GP says, make sure you do not miss your tenormin, or maybe I can increase it double for the time being. Slightly high, the specialist gets a call that I think I need to revise your blood pressure value. You need to come on consultation and we'll change your medication. The last is automatic. Ambulance will be called. That is up to the patient's requirement. The ambulance will go straight to the patient's home in America and England. In Pakistan, we have private ambulances as well, so we can set up this in Pakistan. Thank you very much for this very, very patient listening. So I had straight to be a short of time, so I'm just going to straight dive into the questions. The very, very able panel is sitting here. This is about 40, 50 years of experience of medical industry sitting here. So I dare ask any questions, but can I put some questions for Bilal, who chairs this panel? Professor Bilal is my class fellow, I'm proud to say that. I want to say that because he's done so much for the medical profession, and I want you to do this for the PSIM as well. Please, Bilal. This is the question in front of you. Please fire away your answer.
So the question's, what's the therapeutic value of reducing time?
Please speak louder.
The question is, what is the therapeutic value of reducing time to medical intervention? Is this an objective of virtual home care? So let me tell you this. There's only very few times in our lifetimes in which you have things which are disruptive. So you may have heard of disruptive technologies, and I'm seeing this happening right now. So what Sohail is talking about is actually a disruptive technology in medicine. One thing which happened, which I think the pandemic told us, that all of medicine, the way we practice, is mostly it's reactive. So you are sick, you get ill, you get to go to a physician, they diagnose you, they react to it, they give you medications, you do well or you don't do well, you go home, and then you get sick again, and the same vicious cycle starts again. But it was all changing to predictive medicine now. So I can tell you, I practice in the US, and companies like Amazon, so data is king. So they are all looking for data. So they're looking for data to predict what's going to happen to your health and intervene before bad things happen. So this is like connecting the dots. We were hearing all about this lifestyle and all that. What Suhail's slide showed basically was about the same disease manifestations that they were showing in the previous presentations about chronic diseases. About 80% of healthcare costs are spent on 5, 6, or maybe 7 chronic diseases. Congestive heart failure, COPD or chronic lung disease, wound management, atrial fibrillation, diabetes, and psychiatric diagnoses. These form the basis of most of the money spent in healthcare. Now, what if you can have something like what Suhail has, which can actually predict when you're actually going to decompensate, step in early. So, prevention is the best medicine. What is the second best thing? It's to prevent things from happening, or maybe early intervention. So this is exactly what he's talking about. If you intervene early enough, you prevent that disease from worsening and making you come to a hospital. I'm actually the chief medical officer of a very large system. We have about, I would say, 1.5 million people within our under our care. It's a managed care. We call it managed care. And if I look at the patients in the hospital at any given time, about 80% of these patients could be managed at home. They come to the hospital because they cannot be managed at home. Now, what if you can do something like this? You can manage these people at home for about maybe 90% less cost, much better way. They come to the hospital, get infections, all those things happen. They get delirious, they get all other things. They fall, they break a bone. All those things can be prevented if you can take care to their homes. So I think I really, the database that you have developed, I've looked at Amazon's database. It kind of resembles that. But what they don't have is what to do and how to intervene when something bad happens to prevent bad things from happening. This is what you're talking about today.
So it's a time which is of essence, and I think what it gives us time and quality both. So the next question I want to put to the panel is, what chronic medical conditions in your experience are manageable based on what we just presented? Can I ask Soumya to address this question?
Okay, thank you, Dr. Suhail. I think most of the chronic conditions can be dealt in this way, like diabetes, hypertension, cardiometabolic problems, even cancers, lung problems like chronic obstructive pulmonary disease. Obviously, you cannot manage an acute and emergency situations in home care, but most of the diseases which are long-standing, chronic, they can be managed at home. Because you can, as Dr. Bilal said, that most of the care can be done at home, and in very emergent situations you need hospitalizations. So if you are monitoring your patients continuously at home, it decreases the need of hospitalization because you know the overall situation in the past few days, and if there is a need of hospitalization, you can timely identify it and refer the patients. And when we see patients in clinics or in hospitals, they often bring a blood pressure chart or a blood sugar reading chart for you and a profile. But that is like 1 week ago I had this episode of hypo or a hyperglycemia. And now in diabetes, you all know that we also talk about time in range, that how many times your blood sugar levels were within the normal limit. So we don't want very high and very low levels. So if a patient comes to you after 7 days or a month with a chart, at that time doing an intervention, the damage has already been done. So if we are continuously monitoring them at home through virtual system, we are able to guide them and make interventions early, which can prevent in the long run from acute problems and complications. So I think almost all kinds of chronic conditions can be managed virtually by home, and this is an excellent system which is offering this to us and our patients.
And as you mentioned, Soumya, that the need for hospitalization will reduce with this. So that is an important point. Thank you very much for this very elaborate answer. What clinical support services are required to be incorporated to improve the monitoring accuracy? I want to ask this to Farhan. Farhan has a lot of background experience of managing all these diseases, as he's seen this from a distance and from close by. Farhan, what do you say to this?
I think it's the need of the time, and especially with with COVID, we saw these communicable diseases are increasing, and we'll be seeing more of these infections coming in, and so I think it's important for the physician also to not be in direct contact with the patients. It works both ways. And the patients have to be, isolated many times. I'll talk about that first because infectious disease is my field. And I think the diagnostics is very important. As Soumya mentioned about diabetes and other things, especially, I've also seen my qualification was written like a PhD because I go with Dr. Mushtaq's opinion, but I am a physician trained in Brigham and Women's, and I was at Harvard also. And my field is infectious diseases. So the other thing is that what we are seeing is the lifespans are increasing in my point of view because the people are becoming more health conscious, diagnostics is improving, and medical treatments are increasing, and we are seeing a lot of elderly patients. And elderly patients to commute is difficult, and to monitor them is very important. Now Ramadan is also coming, and we know that sugar fluctuates. And especially the time between 3 p.m. to the sunset is a time when we can see for blood pressure patients and for diabetics, it's a big challenge, and they go into hypo also. And if they are being monitored at their home, at their place, it's very critical. Second, I would like to add that this home service is also very important because it's like we never talk about the caregivers also. So I mean the caregivers, with such a economic crisis, financially they are challenged. Sometimes they are not living at the same place as their elders or the people who need the care. Third, they are already overwhelmed with their children, with their own issues, with their own problems, that they are unable to give that type of a care and take those emotional decisions to be taken and the expertise needed for medication also. So I think it is not only very important system for the people who need help, but I think the help is also needed by the caregiver who are going through a burnout and are really emotionally challenged.
I think it's a wonderful answer, economically challenged, but let's not forget one thing more. We are logistically challenged. The traffic issues, the blockages, the road interruptions. A virtual home care monitoring system means the patient is with you 24/7. That bypasses a lot of hindrance. Please take note of that. So the next question I want to ask, that as a nurse coordinator, if you're a nurse, how is the patient's dashboard managed, and what changes you see and how do you react to that? Kirsty, you're here. You've seen this all very close by. Tell us what your experience has been.
Yes, so from managing the dashboard at the health bank, we've recognized an improvement in prevention of hospital admissions. So obviously with early intervention, we can intervene and get some treatment for patients at home. So it helps prevent them going back into hospital. And early escalation, so once we notice that there is a change in their vital signs, the GP is immediately informed, who then escalates that as well. So the dashboard is really helpful, and the remote monitoring is great. The patients love it, and the families also prefer their relatives to be at home, so that's also what we're trying to improve there. Everybody's really happy with the system actually, and thank you, Doctor.
Thank you. So we'll just do a second round of questions before I take the questions of audience, if they still feel the time is very close to lunch, so I want to wrap it up as well. But this is an important question, that how does it help improve the coordination between different people working together? In Pakistan, in my country, in our country, we have a big problem of coordination. Handover. Kirsty spoke about handover yesterday. People don't give enough information at handover. And a lot of people who die, complications of coordination are there. So Bilal, you work in Center of Excellence in Rochester, New York. How do you see home care improving coordination between different healthcare providers, junior and senior and everybody?
You know, this is the bane of our profession, is lack of communication. So you see a patient, you diagnose, you give them medications, you send them home, and there's no communication across a team. So this is, treating a patient is a multidisciplinary approach. You cannot just do it alone. So you have to be a part of a team that you just described. So there have to be nurses, there might be wound care nurses, there may be people managing the diabetes, the blood pressure, this, that. And unless they're all talking, we are all kind of in the dark about that patient's overall big picture. Unless you do that, you're not looking at the patient's overall health. And we see it all the time. So when we get a patient who is discharged and then readmitted, the number one thing we find, which was a breakdown in communication. So if you have a platform, that the one that you were describing, in which you can gather all the data together, there's somebody which is watching over it in entirety and is talking to different people to make all those connections and all those links. That actually is, again, I will say, that is predictive medicine. So you can actually step in before things start to break down. Just a small story. So a lot of people now have smartwatches, like an Apple Watch or something. So we did a little kind of project in which the watch picks up if you have an irregularity in your heart rhythm, if you have atrial fibrillation or whatever. And then, you know, we said, all right, you have this, and then we had somebody looking at all these people. Interestingly, one day, there was like about 400 or 500 people who went into atrial fibrillation. And we said, what happened? And actually, it was a football match in the US, and the wrong team won. And they all went into atrial fibrillation, or they had an arrhythmia or something. But they did not come to the hospital, because we could connect them with their physicians and say, this is what happened. It's a momentary thing. They are going to settle down, and their heart rate settled down. We did not have that information like what you have as well. Half of those people would have come to the hospital. They might have been gotten admitted. They may have other things. They may have gotten confused. They may have fallen down. They may have broken a bone. All those bad things happen. One thing I would say, I treat, you know, people approach me a lot from Pakistan about patients. One thing I see all the time, and you know, this is something I wanted to mention here. This is Society of Internal Medicine. So they will WhatsApp me a picture of their prescription and their X-ray and their MRI scan, and they'll say, "Buja to jane." I mean, what's wrong with me? I said, what am I supposed to tell you? You know, what is the story? What is your history? What is the overall big picture? They don't know. Their physicians haven't told them. They have no idea. They have joint pain. They'll go to an orthopedic physician. They have this thing. They'll go to somebody else. There is no collection. There is no point in which the data is all connected and you can connect the dots. So that's exactly what we're talking about.
So the working document stays as an integral, pivotal point between all the caregivers at every level. And also, you know, how will this benefit patients? We are doing it for patients. Soumya, do you have any thoughts on that? How would it benefit patients?
As I said, if we have...
Sorry, sorry, Bilal, my apology. I wanted to ask this question to Soumya.
So, Soumya, you are a better...
Thank you, Bilal. I'll apologize to you later as well.
Okay, I think the remote monitoring can overall improve the healthcare system. Not only the patients will benefit from it, but the physicians will benefit as well, because they will have a deep insight into what's going on in the life of the patient, because they will be monitoring them from time to time rather than one single visit or visit after a few months. And secondly, they will be able to guide them timely. And I think in implementing this system into our healthcare would go a long way in improving the patient care. And this remote monitoring system can give you a lot of background information when the patient visits you in the clinic in person, because you already have the story. The same thing that Dr. Bilal said, that sometimes patient comes and you say, what is the problem? So what is the issue? They say, that's why we are here. You have to identify the issue. So you can identify the issue only if you have the background monitoring in place. So I think it's going to go a long way, and I think we are running a little short of time, so we can end this discussion with the note that virtual home care, just like Dr. Suhail used to say, that I used to say that telemedicine is the future of medicine, and he used to say telemedicine is the medicine. So probably virtual home care might be the future of the medicine, and it's not only the future, but there is a need to implement it now to to decrease the cost of hospitalization, which will in turn benefit the overall healthcare system. And I think with this note, we can, move on to our next session.
Well, thank you very much, Soumya. Telemedicine is not the future, it's the future is now. But I just want to have 2 quick 30-second responses from Farhan and Kirsty, and then we close the session. Integration of Path Lab within the system. How do you see it, Farhan?
I think it's critical because, as COVID came, it's like the diagnostics has become more important and the realization is more. And it's not about only diagnosis, but monitoring. And monitoring the progress and monitoring the effect of medicines also on other parts of the body. And I think the system now, everything is cloud-based, it is all digital. So digital is the world, and especially collaborating with artificial intelligence into it, with your system and our systems. The findings are very clear because sometimes the doctors are overwhelmed by seeing too many clients and patients. So they get inferences also, which can help them move fast. So I think the diagnostic which is now there is really, and more things are coming in. And like COVID now is affecting different parts of the body, and as we heard about post-COVID syndrome and many other things coming, we need to monitor the whole body as a whole, and a lot of specialities have to be involved, which can be only through this system.
Thank you. Before we close,
Sir,
the last...
Just quickly say, so one thing that you mentioned is very interesting. So because of these kind of platforms, we have a lot of information. So you mentioned artificial intelligence and machine learning and all that. So we have to prioritize the data to get to the right kind of patient. So that's something that you probably have in your system, but we can talk about it later. But that's important as we go forwards with these technologies.
Yeah, artificial intelligence is the third person in the room. Doctor, patient, and the artificial intelligence third person. Last question, 30-second response from Kirsty. Lifestyle management. Do you see a role virtual home care in lifestyle management?
Yes, so we've got a lot of patients who are on our lifestyle management program. It's basically like having a coach, someone that oversees everything you're doing, especially for diabetic patients. They report to a nutritionist who advises them how to eat, live their life. We've had loads of success stories with that. The positive is that obviously they don't have to come to clinic. Everything is done remotely. All of their sugars are reported back in the system, and the database keeps a track on everything. The patients live a normal life. It's just like having a coach or a personal trainer for your diabetes and things like that, and your weight loss. It's been a real success, actually. Patients are really happy with it.
It's a personal trainer approach. Well, thank you very much. I'd love to include you all in this, but I'm hearing the time is very short. But thank you very much for your patient listening. Thank you.
So in the name of Allah, the most merciful, the most beneficial. Assalamu alaikum, everyone. I welcome you all to this session. I, Dr. Amna Mausam, will be the moderator for this session. We will start by inviting and introducing the chairperson and the panelists to the